Let's talk about the policy and procedure manual. Why do we have a policy and procedure manual? Sometimes we abbreviate that P&P. Well, it tells us everything about the job and how to do everything. If there's an outline of what to do in your job, there's less room for error or mental fog. Everything we cover is not going to go over all the iterations or depths of every hospital or lab manual, but this will give you a good overview of what manuals are and how they work. If you're anything like me, you like to stay out of trouble, and staying out of trouble means knowing the rules and knowing what is expected of you. Usually training is the way you learn about how to stay out of trouble, but if I'm honest about all the training I've had for every job, the training was not much. But if the lab is accredited, it has to have a P&P, which is it's going to have a blueprint or outline for just about every aspect of your job, and you can essentially train yourself. Policies are courses of action and describe what the following procedure will detail. They include laws or standards that are required, prohibited, or suggested. These are developed for situations that occur over and over. You can think of them as statements that guide organizations in their decision making. For instance, a policy might read like this, in quotations: "It is the policy of Pitt Community College Sleep Program that all staff members hold a current AEDBLS certification." And that's all there is to a policy. What comes after and details the protocols are called the procedures. Policies are very generalized, and procedures are more highly specific, but don't need any interpretation. So procedures are a step-by-step or chronological list of required actions to implement a policy, all the things that must happen to make sure a policy is fulfilled. These documents are highly specific and detailed and written to the point that they're highly understandable and they don't need any interpretation. Having procedures that everyone follows makes everything consistent. Everyone runs reports the same way, everyone scores mostly the same way, and everyone follows titration rules the same way. The more consistent everyone's work is, the easier the work for the provider overall. This is a part of one of the policies from a lab that I worked at, and it's well organized. At the top, you can see we have headers. We have policy numbers. We have dates that it's been revised and implemented. We've got the policy title. We've got the department and the division. This is the policy to ensure proper prior authorization is obtained for all sleep studies when indicated. Very general. You need a little bit more information if you want to know more about that, so there's the procedure for it. And this heading is standard for the entire manual. These things can change, but this doesn't. The table, the division, department, and policy titles stay the same, so everything is very organized. And I've worked in labs where they've just taken sections from other labs and put it in their old manual with the original header and everything, and that's incredibly disorganized and an inappropriate way to build your own manual. For this, the policy is short, direct, and to the point. The procedure takes a step-by-step approach to listing each individual situation, and in this case, on how insurance authorization is handled. Again, policy and procedure manuals are essential for a uniform response to all things, including emergencies, standardizing testing and quality assurance, and consistency is the key. Manuals can't be locked in an office. They have to be available all the time. When I worked at a lab, I could access it on their intranet when you're on their computers or in the binders that are right there in the tech room. The most current AASM practice parameters should be used as the standard for these test protocols. It needs to be highly organized in sections, easy to locate, not too big, and not messy with documents hanging out. The employees need to get to them immediately, especially in emergency situations. In fact, I think the best labs have emergency protocols or rules for titrations or special study requirements right there at the workstation. That way, if anyone has any doubt at all, they can just refer to the manual and know for certain what needs to happen. Although you want your procedures to be specific, you don't want to inundate the reader with every piece of evidence regarding CPAPs or whatever the policy is about. You need clarity so it's not confusing or too much to read all at once, especially if it's an emergency. You want brevity, which means not being too long. Use of direct language. If you see this type of arrhythmia, like for instance, if you see this type of arrhythmia, you can try and go back through the record and see where it begins and see if the respiration rate dips or if the O2, well, that's a lot of words for nothing. You want the words to be as pointed and clear as possible. Each policy should be very specific in defining when it is considered an emergency. It needs to refer to types of events, specific values, or specific time frames or lengths each event needs to be in it for a real emergency. If you have a patient in ventricular tachycardia, which could be a life-threatening arrhythmia, you want to check the pulse ox. You want to check and make sure the heart wires are okay. You want to take a manual pulse. You want to make sure their oxygen saturations are okay. For patient-reported events, you really need to listen to the patient. You need to ask questions like, has this ever happened before? What did you do the last time this happened? Have you seen a doctor for this? You need to familiarize yourself with the patient, with their chart before they even get there. Call the medical director for patient-reported cases. You might also want to call a family member with the patient's permission. HIPAA is a big deal. You can't call people if they don't want you to, and usually they have to have some sort of documentation for people that they can do that for. I've had a patient that took way too many tranquilizers, and she kind of lied to me about it. And she would not wake up in the morning, and I had to go home, but I ended up getting her to access her phone, and I got her to let me call her son. And that was kind of an emergency situation because she was basically unresponsive, and not a safe situation. You want to get those people out of the lab as soon as you can, just in case something happens. So the manual needs to state specifically in cardiac cases which arrhythmias are considered emergencies. How many PVCs do you need? Um, as a sinus pause greater than 3 seconds. The manual needs to state how low the pulse oximeter can go, or how high the concentration of CO2 can go before it's considered an emergency. You also need to make sure that these things aren't um, artifact. Sometimes you might get a real weird uh, heart arrhythmia, but really one of the electrodes has fallen off. So that's important too. It might be an emergency, but you need to make sure your equipment is correctly telling you it is or is not. A good technologist knows what weather is potentially life-threatening and knows what to do in any situation. I personally have called the police twice. One for a Down syndrome patient who was really aggressive and violent just in the waiting room. And he took a swipe at me and had called the cops, but the situation was fine. It resolved normally. And another time when a patient had actually fainted walking to their bed, and when I saw him, he was face down on the floor. I got him to regain consciousness with an ammonia salt inhalant. But when he came to, he was really out of it, and he was stumbling down the halls. And this was a big guy, not just like overweight, but he was really tall, and I couldn't help him. He could have really hurt himself falling down the stairs or getting into chemicals or the Sharps equipment. So the emergency plan is when your inner mother comes out. You want to protect yourself, the patients, and the lab. We have these emergency plans so that when one happens, you know exactly what to do and you don't have to think too much if there's a blueprint on what to do right there in front of you, especially if you familiarize yourself with it. So these manual entries have many sections. It identifies who the medical director is, who the on-call physician is, who the supervisors are, all with their names and contact numbers. How to contact emergency personnel. Should you call from your phone to the lab phone, or do you have a panic button? Both labs I worked at did have panic buttons, and it's just a little, it could be a remote control that sits in a drawer, or it could be a little button under your desk. And you typically want to hold it down for a long time, like 5 to 10 seconds, and that will alert the police to come, and they'll come and see you if you do that. Uh, you want to know ahead of time what to say to dispatchers in the event of an emergency. You should be ready to list what kind of an emergency it is, the vital signs of the victim, and more details about what happened. The name of your patient, your name, the phone number and address of the facility. You should tell them where to come in and if someone will be waiting for them. Usually, if emergency personnel are involved, this is a medical emergency. There are a million ways that emergencies can play out, and it depends on if you're in a really old or a really new hospital, or if you're in a private setting. You might have 20 other technologists working with you, or four, or you might be by yourself alone in the whole building. And so these are some things to consider when having a P&P manual. Do you have enough people to get one person to call 911, get one person to start CPR? If you're all by yourself, you have to do all of this by yourself. And you have to know a priority of which to do first, which is the most important. So that's something that is very lab specific. You can have your own emergency thing for what you want to do, but you really have to follow the P&P because that is supposed to be really well thought out with the patients in mind and also you in mind as if you will have help or not. Typically, if you're running patients by yourself, you're not going to have uh, someone extremely ill or anything like that, especially in a private lab. So all the supplies and wires that are specifically used for the lab's equipment and software have to be listed in a policy. Different software have different requirements with different other software and hardware, so they all need to be listed correctly in the manual. For supplies, there are all kinds of tapes and adhesives and chemicals used in the lab, and these need to be listed in the P&P as well as their indications or contraindications. If you use collodion, which is kind of like a special super glue that you can attach wires to on the head, and it dries really nicely and really won't come off easily. Uh, you don't use that on asthma patients because it's got they have fumes, and so sometimes asthma patients can react to that. All those things should also be found in the MSDS. Sensor placement is always going to be based on the 1020 International EEG hookup system. Logical steps. There are certain things sleep techs do differently, so a hookup can be a little different as long as it all gets put on correctly. It should, however, describe the ways all the sensors are to be applied. For the location, do you hook up in the patient's room, the tech room, or is there a hookup room? Maybe comfort is an issue and you need to change the plans a little bit to accommodate your patient. I've had one patient that wore a hijab and I was by myself. We didn't have a lady technologist to accommodate her, so That's one thing that a good scheduler can do is they can recognize these kinds of things and uh, make it the most easiest for the patient and the technologist. But she didn't really leave her room. We have a hookup room and everything, but I brought everything into her room because she didn't want anybody to see her, and me seeing her was enough. So, non-malfeasance. Don't scrub. Non-malfeasance. Non-maleficence. Come on, Rob. Non-maleficence. Don't scrub on diabetic legs. Don't put electrodes on broken skin. You don't want to diabetic skin, especially on their extremities, especially on their legs and feet, have very uh, poor skin, and it cracks and it gets very dry. And if you scrub at all, a lot of times that'll just make them bleed immediately. So you got to be really careful with certain people. Old people have very fragile, delicate skin too, so you've got to be careful with things like that. So different software have different steps to accessing the study platform. So specific steps on how to use the equipment must be listed. Some of the standards, like how long a sleep study has to be, the last minimum standards as set by the AASM, but individual labs may vary on how long or late patients may stay. Some physicians may want video to be recorded the whole time the patient is in the room. Some might just want it when the study is recording. Certain documentation is done within the NPSG software, but that also might be required to put on separate sheets for additional documentation, like if the doctor wants all that documentation from the study to be put into the patient's chart. Not every lab does that. I've seen labs that have papers for impedance checks, papers for the chronology of events. It can be as micromanaged as they want it to be. The frequency at which you document in the study should be listed. Uh, some doctors want you to put in the heart rate, the sleep stage, and the pulse ox every 15 minutes. And personally, I think that's silly because really what they're looking for is to see if you're paying attention. But on a lot of these softwares, you can go back and put it in when you look back at the study. So that doesn't really make you pay attention. And the doctor can see all that information right there in front of them. So the more important documentation is, we'll talk more in depth about it, but the when you should document, that's something that the doctor, if they really want you to do that, it will be in the P&P. Also, the procedure on how to help the patient get in and out of bed should be listed. My old lab had a Hoyer lift, so if we had patients up to 500 pounds that couldn't get in bed, we could help them get up into it. For a typical parasomnia hookup, you would have a few extra wires, namely FP1, FP2, T7, T8, CZ. Sometimes the physician will add EMG wires to the forearms for additional limb monitoring. Some on the masseter muscles on the sides of your cheeks for bruxism, or on the back of your neck for head banging or head rocking. A lot of pediatrics are known to do that. All these have to stay on because if you're looking for specific things and it's the main reason they're having the study and they're not on there, well, then why are we having the study? So specific things like that have to stay on. Sometimes you can get away with certain things falling off, like C4 sometimes falls off. That's okay. You don't have to go in. But all these other things, you really want to keep all those on. And if you're a very, well, it's either do you go in or do you not for certain things. You have to read it. Technologist to technologist, it's different. All CPAP masks don't fit the same way. So different sizes will fit different faces differently. The patient mainly determines the style of mask based on their comfort, but if they can't sleep with their mouth closed, it makes it harder to use a nasal mask alone. So, documenting the type and size of all the masks used during the patient's stay and the patient's reaction and their preferred mask should be kept. the patient becomes desensitized in phases. Holding the mask to the face without strapping it on, then strapping it on, turning the mask on, letting them breathe on it for a while, turning it off. Then you do it all over again until they get used to it more. Different labs are going to have you do that different ways too. Labs have a set criteria to split a patient, and usually it involves the latest time of the night to split, like if you have a cutoff time at 12 a.m., the sleep time necessary to split, usually it's 2 hours sleep time. If all the sleep stages are met, you got to have most of them. A lot of places want you to have REM. A lot of places also want you to have supine and lateral sleep. Make sure that one of them is not protective against sleep apnea. How much time is needed for the diagnostic and the treatment phases? You may need even more time for the titration if you have to convert from CPAP to bilevel. It just depends on the lab. Labs may have different starting pressures, but they usually start around 4 to 6 centimeters unless it's a retitration, in which some labs will still insist starting on 4. Some will want you to start where the patient is and then either go down or up. Again, documentation is important to show the doctor that all of these aspects to make their decision easier. There's not a slide for ASV or other modes, but it would really follow similar directions as it would for switching to bilevel. Usually titration studies are assigned as CPAP or bilevel or ASV titrations, and you don't really have to decide. If a patient has been assigned a diagnostic but they've been on CPAP currently and they just need to be retitrated, maybe you talk to your supervisor or call the doctor to clarify. Make sure there's nothing in the notes. They may just be reassessing the patient's sleep apnea without CPAP. Manuals will describe when to increase pressure and how much. Usually you wait 5 minutes before increasing PAP 1 or 2 centimeters for snores, hypopneas, or apneas, and you would decrease PAP 1 or 2 centimeters for central activity or for down titrating purposes. Down titrating is trying to find the exact right pressure. You've gone up and up and up, and now they're not showing any obstructive symptoms. Once you've got that in all positions and all stages, then you start to back off the CPAP to see how low you can go, and that dials in their pressure even better. Humidification should also be considered if the patient's mouth is dry, if their mouth opens when they're asleep, or if it's too hot or too cold for the patient. Some patients don't care for humidity. Contraindications are reasons that PAP therapy is not recommended. Like you wouldn't want to put a person with a collapsed lung on CPAP. That is listed as a contraindication. Sometimes if it's obvious that the patient needs advanced PAP, like bilevel or ASV, but the provider wants to be called first to approve it, then the physician needs to say that in the protocol. The CPAP max pressure on machines is 20 centimeters, and bilevel can go up to 30. But your lab might have different procedures and might not want the pressure to go that high, so you've got to make sure you're not uh, giving the patient too much pressure per your lab. Some of the only differences in CPAP and bilevel include adding IPAP on top of the EPAP, when to increase or decrease IPAP or EPAP, when to use spontaneous mode or spontaneous time mode or just time mode. There are a lot of other features on bilevel that will accurately dial in exactly what the patient needs. It all depends on what the manual says. You're going to learn so much more about all these titration methods that we're just talking about everything that you need to have in the protocol. And later on, it'll be easier to remember all of these things because you'll have talked about it in class. In the sleep lab, it's common to use supplemental oxygen on patients for a bunch of reasons, and they either use these big oxygen concentrators that are pretty loud and they can get pretty hot, or they can use uh, oxygen cylinders. uh, and you could use these for a number of reasons, but there must be a qualifying criteria to follow, as well as contraindications, reasons not to do something. You need to use it alone or with CPAP? where do you start the flow rate at? When do you increase or decrease, and how much to increase or decrease? Capnography is a, is a way to measure CO2, and we use that for morbidly obese patients and pediatrics or patients that have respiratory problems. The problem happens a lot of times they have a lot of weight on their uh, obese patients have so much weight on their lungs that their muscles just can't breathe for them, so they don't breathe enough. And children are pediatrics are more prone to respiratory problems than adults are. And there are two kinds of capnography machines. There's one that's transcutaneous. It's kind of like just a sensor that sticks onto your skin. Or there's end-tidal, which is a cannula. It goes under the nose and it has a mouth portion that goes over your mouth. Just hangs in front of it. Most of these times, these machines have to be calibrated for their software to integrate properly with your computer software. And there have to be procedures on how to calibrate them, as well as every once in a while, the capnograph has to be calibrated itself for the carbon board. When CO2 is measured on the skin, the probe has to be moved every so often, like every couple hours, because it can actually burn the skin. The transcutaneous equipment can be really expensive, and it's more common to see end-tidal in private labs. Hospitals, a lot of times, will use transcutaneous. There are pros and cons to using both, but transcutaneous is thought to be more accurate and easier to keep on because there can be dead space in the cannula. So the lab needs to be maintained, and there are usually lists and dates of site work for technologists or staff to complete. This involves testing the wires, removing equipment that isn't working properly. There are lab-specific ways to deal with these issues, and they go from either just throwing the wire away or bagging it and writing it up to a report. Depends on what the equipment is. All equipment must be disinfected after each use. Also, all emergency equipment has to be up to date, like the AED pads and batteries. Um, they don't last forever. Every couple years, you need to change the batteries and the pads out. You also have to keep a log for making sure that the AED works. That's another P&P thing. You have to list your resuscitation drugs. You have to make sure they're in date. The fire extinguishers are supposed to be inspected. You want to make sure that backboards for CPR are available, and bags and masks are clean and ready to go in case you have to do anything for them. So quality is a measure of the degree to which delivered services meet established professional standards and judgments of value to the customer. What? Basically, it boils down to how efficient and cost effective is any specific aspect of the lab. Some of these quality measures could be CPAP compliance or the Epworth Sleepiness Scale over time. Quality assurance involves activities or programs to make sure the work provided is the best it can be and it meets at least a minimum standard of care. A utilization review is an evaluation of necessity, appropriateness, and efficiency of healthcare services. A Q&A policy must include three measures as well as ISRs. Like I said before, it could be ESS, patient satisfaction, or timeliness of service. This is supposed to be reviewed and reported each quarter, and a plan must be established if the items are not met. A utilization review is the evaluation of the necessity, appropriateness, and efficiency of healthcare services. It's a review that tracks if a measure is useful, needed, and easy to accomplish. It compares the lab's data against other cases that have been published so you can measure how good you are against another standard. ISRs must be completed every month. Score reliability tests. The DABSM, which stands for the Diplomate of American Board Sleep Medicine, they are the gold standard when it comes to scoring. Technologists score the record, and their results usually about 200 epochs. They'll pick it out, and you score the record, and your results are compared to the gold standard. Typically, you've got to be in agreement with 85% of what the events and stages are scored as for theirs. This can either be completed with ISRs online, or a study can be selected from your lab. For the ISRs, you stage sleep, you score the arousals, respiratory events, and leg movements. All the results from these ISRs must be kept for documentation and to track progress. If the ISR scores are not at least 85% in agreement, a plan must be enacted and followed to correct the problem. The AASM says that the P&P must be sufficient to support safe and effective patient evaluation. Exclusion criteria is based on what level service the lab can provide. It excludes patients based off of certain things that you don't think the lab can handle. Can you accept children? If not, what's the cutoff? 18? If you can take children, do you accept infants? Can you accept someone in a wheelchair if they're immobile? If you're on the second floor and you don't have an elevator, probably not. Can the lab accept severely sick patients, like those with bad cardiac or respiratory issues? There was a story in the news not too long ago about a sleep lab and a pediatric patient with asthma needing oxygen, and I don't think they gave it to him because they were trying to do the diagnostic portion, but that kid ended up dying. So someone did not do their job. Either they didn't follow the policy and procedure manual correctly, or the policy and procedure manual wasn't written correctly for the patient's own safety. So they have to check that the order conforms to the AASM indications for MPSG, or whether they need a sleep study or not. So that's it. First one's in the books. Thank you for watching. If you have questions about anything, documentation is my thing. And I'll probably talk later about my methods of documentation and everything that I do for it. But that'll be later. So, see you later.